So for our evidence synthesis, we had cognitive behavioral interventions.
We looked at articles that involved acceptance and commitment therapy, or ACT, and cognitive behavioral therapy, CBT. ACT is learning to accept circumstances and feelings, whereas CBT involves learning to reframe negative thought patterns. Both of these interventions are used commonly in adult populations to increase quality of life. Research says that this intervention is helpful for people who experience chronic or acute stress, regardless of their source or circumstance. This includes populations such as those who are living with chronic conditions, caregivers, and parents of children with disabilities. One of the articles I looked at showed a significant improvement in stress and burnout, and no significant differences were observed between ACT and CBT interventions. Additionally, there was a decrease in psychological inflexibility, perceived stress, psychological distress, and suppression of private events that was observed after intervention. These changes were sustained in the follow-up phase 2 months after the intervention. The first article was a qualitative group study with more rigor, which was a level 2, and the second was a quantitative group study with less rigor, a level 3. Overall, there's a plethora of research that supports these two interventions. These articles are relevant to occupational therapy because they address the thought patterns that influence feelings, behaviors, and actions. This approach allows OTs to be holistic when working with individuals with complex life circumstances. An unintended result of these interventions was also reported. This includes the improvement of child-parent relationships or caregiver-survivor relationships.
Another intervention that we looked at were visual activity schedules. These are considered to be evidence-based practice that is frequently used with the pediatric population, but it also can be used with adults. Visual activity schedules help orient children and establish predictability for the day's events through the use of pictures, symbols, and/or written language. The aim of this intervention is to promote on-task behavior and facilitate independent transitions. One article that I looked at found that visual schedules can be considered evidence-based practice for individuals with ASD. The review found the intervention to provide structure and helped reduce problem behaviors. The visual schedules were found to be an effective intervention for individuals from preschool through adulthood. The second article I looked at suggested that visual schedules can increase consistency of classroom engagement and performance. Findings discovered that engagement remained high even as verbal prompting decreased over time. The article suggested that visual schedules can be an effective intervention for young children with challenging behaviors who do not have ASD or an intellectual disability. And then in terms of level of evidence, the one article was a descriptive systematic review, level 2. And then the second article is experimental single subject study, level 4. So overall, the research supports the use of visual schedules with the pediatric population. The intervention was found to increase engagement levels, decrease problematic behaviors, and increase independence in daily tasks. Visual schedules can be beneficial for children of all abilities, not just those with a formal diagnosis such as ASD. This intervention is relevant to occupational therapy practice as it promotes on-task behaviors and enhances focus/attention. These behaviors and cognitive abilities can positively impact a client's academic performance and increase their independence in daily occupations.
Applied behavior analysis, or ABA, is a therapy primarily used with children who have an autism diagnosis. The concept of this intervention is based on the idea of reinforcing behaviors to achieve desired outcomes. ABA therapy is controversial for 3 main reasons. The first being that the original version of ABA used punishments as well as rewards. Punishments are no longer used, but critics believe it is still too hard on children due to its repetitive and very structured nature. Additionally, critics say that it is more focused on eliminating behaviors rather than building skills. And lastly, critics say that it lacks flexibility and desired outcomes, requiring children to meet neurotypical standards. The first article that I looked at involved students in a community-based early intervention ABA program. They demonstrated improvement in cognitive, communication, motor, and social emotional scales as seen by the scores of the Bayley Scales of Infant Development 3. The second article, participants were enrolled in an early intervention service, who also had a diagnosis of ASD and had eating challenges. With parents and tutors in the position of the therapist during mealtimes, ABA intervention was found to decrease the number of food rejections. One article was an outcome one group pre-post study of level 4, and the second article was a quasi-experimental, non-concurrent, multiple baseline level 3. So evidence indicates mixed reviews for ABA therapy. Both articles in this used in this analysis describe the positive results of ABA therapy as it pertains to the intervention goals of eliminating certain behaviors or instilling new behaviors. That being said, participants are children in early intervention programs, meaning that they are not old enough to provide qualitative input for the study. Among the critics of ABA therapy are individuals who received the treatment when they were children. These individuals reflect on and describe their experiences as traumatizing and negative. While it's possible for ABA therapy to extract the desired behavioral results, caution should be utilized to prevent trauma at all costs.
The last intervention that we looked at was PASS. This stands for Promoting Alternative Thinking Strategies, and it's designed for school-age children, specifically preschool through elementary school. PASS aims to help children learn how to recognize and manage their emotions, build positive relationships with peers, and make responsible decisions. The program provides a structured framework for teaching these skills using a combination of classroom lessons, role-playing activities, interactive games, and discussion groups. The first article I looked at suggested that PASS can strengthen social emotional skills and decrease difficult behaviors for elementary school-age children with aggressive tendencies. Teachers noted less aggressive behavior, less conduct problems, and less acting out problems with students who received the PASS intervention. The second article I looked at found that PASS had an impact on elementary school children's academic progress and performance. The research found that it had no significant impact on their academic outcomes. The authors did not recommend PASS as an effective intervention for improving academic performance in school-age children. However, the authors did state that this intervention may be beneficial in other ways. So the first article, or both articles, were experimental, randomized controlled trials, and level 2. So the evidence supports the use of PASS in a classroom setting and has been proven to help reduce aggressive behaviors and behavioral disruptions in the classroom. Evidence suggests that even though PASS is effective in making behavioral changes, that this does not mean that academic performance is improved. This intervention can be a valuable tool for occupational therapists to use in a school setting, collaborating with the teachers on the best way to support their classroom dynamic. Additionally, this intervention correlates with OT practice, specifically in terms of emotional regulation and social participation, both of which play a significant role in the students' behaviors and academic performance.
Typical application for ACT and CBT includes stress reduction for individuals with chronic conditions, burnout reduction and prevention for caregivers, and decreasing psychological inflexibility of self-directed clients.
For visual activity schedules, the clinical application, it's first proven to be an evidence-based practice. It promotes independence and routine by making daily tasks more manageable. It can improve executive functioning, and it can reduce anxiety and behavioral outbursts.
ABA can improve cognitive and language function, specifically with individuals with ASD.
And PASS can support children with aggressive behaviors, anxiety, and difficulties with social interactions. It can also address a range of mental health and behavioral concerns with the pediatric population.
A few future research ideas include identifying the most effective education method for caregivers so that they can make an informed decision about the use of ABA therapy. Research regarding how ACT and CBT can be utilized in a community-based or interdisciplinary context.
Additionally, research can work to investigate other pediatric diagnoses, such as other developmental disabilities, ADHD, or expressive language delays, and how visual schedules can impact their functional abilities. Research regarding visual activity schedules on portable electronic devices, such as iPads, tablets, or iPhones. And then determining whether the implementation of PASS in the classroom has any impact on behaviors in other aspects of the student's life, such as at home, grocery store, sports practice, etc.
Our first discussion question involves your experiences in clinics. During clinic sessions, would you implement any of these cognitive behavior interventions with any of your clients?
Our second discussion question is, have you used a visual schedule with your clients? What did you like or dislike about it?
And why do you think ACT and CBT interventions improved child-parent or caregiver-survivor relationships?
And then these are our references. Thank you for watching.